This is Karen with NewClevelandRadio.net, and it is time for Lessons Learned. And today's lesson is about female health and a very special subject that is something that I'm going through is called pelvic prolapse. And if you've never heard of it, you may start to understand it when we talk about some of the symptoms. And I have Dr. Rachel Miller with us today, and she's going to sort of you know, give the medical side of it. And remember, she's not diagnosing you or me. She's just sharing information about the syndrome itself. So thank you for joining us, Rachel.
Yeah, thank you for having me.
So, talking about pelvic prolapse, it's sort of a new term that we're talking about, isn't it?
I don't know how new the term is. I think it's definitely getting more commonly talked about. There's a lot of research studies out there that try to kind of pinpoint how common it is, and I think it's one of those things that is hard to know because a lot of women have it but don't have any symptoms, and so they therefore don't know that they have it and don't do anything about it and don't seek out help. Um, so it's one of those things that I think is hard to put a number on, how many women have it. But I mean, there have been studies out there that have showed 80% of women who have had one baby will have some sort of mild to moderate prolapse, which is huge numbers. And I think it was a similar study that showed out of that 80% ish, like only 6% have symptoms. So it's a very small subset of women who have prolapse that have symptoms. Um, Obviously, when prolapse is severe, most people know, but when it's more mild, a lot of times you don't know. And in our medical world, treatment is very reactive, meaning something's wrong, then we try to fix it, versus preventative and proactive. And I think that, I mean, obviously for obvious reasons, when you have a baby, your uterus grows a whole lot, like everything stretches and expands. And when it's all done, it doesn't all just shrink back and go perfectly back up to, where it started, kind of like after breastfeeding too, right? Not everything is the same, right? We have stretch, we have gravity, things shift a little bit. And essentially that's all a prolapse is a little shift, a little descent in the organs from where they started. And it could be the bladder, it could be the rectum, it could be the uterus itself, it could be all of them, none of them, some of them, like there's no rules, but that's where you'll hear like cystocele, erectocele. That's kind of talking about which individual organ has kind of descended a little bit more. But really, it's just a shift in position. And so it's almost like a normal change post childbirth to some degree, right? When you have symptoms, obviously they want to address it. When it's more severe, you want to address it. But as a women's health physical therapist, a lot of what I do is education in terms of as your body's healing post childbirth anyways, there's strategies and things that we can be doing to not put more stress on the pelvic floor. And I do believe that over time, if we keep bearing down and putting pressure down on our pelvic floor, and then we have gravity and all of those things, and then menopause, we get more hormone changes. And, if maybe we didn't have those strategies for 20, 30 years, in between childbirth and menopause, maybe we could have prevented some of these prolapses from becoming worse. Maybe we could prevent them, from becoming symptomatic. I mean, there's no research study that's going to prove, what if, right? But it would make sense that if we're not continuously putting pressure down on those parts, that we may have some better outcomes. And it's not very challenging or hard to do. It's literally education, making sure that you know where your pelvic floor muscles are. And that's about it. So, I think that post baby, ideally, every woman should be seeing a women's health or pelvic floor physical therapist just to kind of get a little checkup of like making sure all the parts are reconnected and doing their jobs and teaching them some of these strategies, which not only may prevent some issues from happening down the road, but also kind of help you get your core. And when I say core, I'm talking like deep core system, like those deep abdominals, the pelvic floor muscles. We have the ability to get those back on track, right after having a baby. And obviously these issues can happen even in women who have never had children. but they're much more common in women who have had children for obvious reasons. Um, so yeah, I think there's a lot of room out there for more education and more preventative measures.
Absolutely. Well, as I've shared on a number of our lessons learned, about 20 years ago, I started getting this deep, intense pain on my right side, almost where the appendix are. And of course, every time I'd have pain and it'd be doubled over, my husband would say to me, "We got to take you to the hospital. It's your appendix." And I'd go, "Well, no, it can't be because I've had this before. It hurts. I'm in pain. I'm doubled up." And then it goes away and then it comes back again weeks, months later. I said, "So if it was my appendix, it would have burst by now." Uh, but every time I asked the doctor about it, um, it was just, well, it goes away, so no big deal. And then I finally had doctors who ran scans and ultrasounds and were doing blood work to see if they could figure it out. And it was like, you're healthy. And it wasn't until I had kidney stones. And after the kidney stones were blasted and I was healing, um, I was in the doctor's office and I had one of these attacks. And they called in one of their specialists who was just down the hall who understood pelvic prolapse. And as much pain as I was in, he was examining me and he explained, "This is what's going on. Your bladder has dropped, your rectum has dropped, and it's causing you pain." And I said, "So now what do I do?" And he said, "Well, you go for physical therapy." So I know you provide that. Um, at first, I was skeptical. In fact, I didn't want to go. And even my first 3 appointments with my therapist, I barely let her touch me because it felt invasive and I didn't quite understand it. But she took those first 3 appointments to talk to me about why I needed the physical therapy. So, can you talk to us a little bit about what the physical therapy is all about?
Yeah, I mean, pelvic floor physical therapy, I think, has gotten a lot more, um, I would say, common in the last, I don't know, 5 years, maybe even. Um, and it's definitely different. And what people, I think, don't know is a few things. And so, like, when somebody schedules an evaluation with me, we kind of make sure that they are aware that we are more concerned. So, as a physical therapist, we're more concerned with the musculoskeletal system. So, your OBGYN is going in there with a speculum, they're checking all the organs and all the big parts. We're going in there with one gloved finger most of the time, and we're checking muscles. And so a lot of that we're checking, just like you would go to traditional physical therapy, where we're checking range of motion of the hip and the knee, we're checking core strength, we're checking hip strength, we're checking all of kind of the bones and the joints and the pelvis and the lumbar spine. So that's no different than kind of if you've been to physical therapy for your back or your hip or those types of things. The difference with pelvic floor physical therapy is, number one, we ask a lot more questions, a lot more personal questions. So we get into bowel and bladder habits. We get into, do you have pain with intercourse or with gynecological exams? We get into all sorts of, bathroom habits, all things like that. And then with permission, we often do an internal exam, which is not ever required, and but it is kind of the gold standard in terms of getting the information about your pelvic floor. We need to know if those pelvic floor muscles are kind of too tight, where they can't relax, versus if they're really just weak, versus if it's a timing or coordination issue, and kind of what your strategies are with how you're using your pelvic floor, kind of with daily life, because it's one of those muscles that people don't really think about until you have a problem. And a lot of people don't have that awareness. Like, if you have tight hamstrings, you know it. If you have tightness in the pelvic floor, most people have no idea. So, that internal exam is kind of a gold standard in terms of like really knowing what's going on. And most of the women that we do an internal exam on are actually really fascinated, because it's giving them so much information and so much more awareness to their body, and a body part that they obviously need to be addressing right now, because they're obviously usually seeing me because there's some sort of problem. But what an internal exam usually entails It's just like at the OBGYN office, you would undress from the waist down, we cover you with a sheet. And then we start with just observation. So what happens if we say contract and relax? Like we're almost looking for like what I call range of motion of the pelvic floor, meaning that it should lift and lower. And if I say contract and relax and nothing's happening, either I'm suspecting you don't know where your pelvic floor is, or those muscles may be too tight and don't know how to relax, or they can't move very well, right? Which then leads to weakness and other issues from there. We're seeing what happens when people cough. And then we actually have 3 layers of our pelvic floor muscles. So the external muscles is where we start. And we just start with palpation, meaning we just kind of take one finger and we're just kind of touching some different areas to see if there's any tension or tightness. And then obviously with permission, and I always tell my patients, like, we don't have to do anything, we can stop at any point, like nothing is supposed to be painful. We don't use a speculum. So it's, one gloved finger that we will insert vaginally with permission. And we'll insert just a little bit and we'll see kind of right at that entry, is there any tenderness? Are the muscles, tight and spasming? Are you able to contract and relax? And then we will move into the deepest layer, which is almost the pelvic bowl. So we can kind of get our finger right into that pelvic bowl and we can go around and see if there's any tenderness or tightness in those muscles. We also then see what the strength is. So, contract and relax. We check the endurance of those muscles. We can check kind of the coordination and timing, and can they move? Can they contract quickly? Can you let go of them? Things like that. And so that's kind of our opportunity where if we do feel tension or tightness, we can do some internal like release work, just like any other muscle, and see how your body responds to that. If the weakness is the issue, we'll start to play around with different cues and different ways to try to get you to find that pelvic floor, where we can then give you really good feedback of like, nope, that was not it. Like, you just moved your whole pelvis rather than actually contracting your pelvic floor. So we have a lot of ways that we compensate, that we think we know how we're using our pelvic floor, but we really aren't. There was actually another research study that took, I believe, a few hundred women and gave them verbal instructions of how to do a pelvic floor contraction. And then they actually went in and measured, like, are you really doing a pelvic floor contraction? 51% of them did not do an effective pelvic floor contraction just from that verbal cue. And actually a subset of them did a pelvic floor contraction in a way that actually promotes incontinence. And so, we can talk about Kegels, but Kegels are not always the answer, because if your pelvic floor muscles are kind of too tight, or if you don't know where they are, it doesn't make any difference. I've also seen women where their pelvic floor muscles are really strong. It's just like the timing and the coordination, they're just not working in the moments that you need them. So it's not quite as easy as just, Kegels for everyone and that solves the problem. It's actually usually not the case. Usually there's a lot of other things that we need to address instead, but it's just dependent on everybody. And then what my practice focuses on is, can you find your pelvic floor? Can we contract? Can we relax? Do you know where it is? But then how do we integrate that into function in terms of getting all the muscles in the core and the body to work together?
So if this is caught early on, um, obviously physical therapy has is better than if you've waited years and years and everything is totally dropped. Am I correct or wrong?
Yeah, I mean, so if you're talking about prolapse specifically, so ideally, so right postpartum, we have like our body's already healing, right? And so we can do things to facilitate it healing in a better position, so to speak, right? So even up to a year postpartum, things are still kind of like resettling, resituating, right? So we have this like window where your body's already healing, where we can totally like take advantage of that. Further down the road, they say that so the way that prolapse is graded, when it's more severe, it's literally coming externally of your body. And that's when women are obviously way more aware, because you go to wipe and you're like feeling something or you see something. And that's usually when people are like, I need to go to the doctor. When it's, more mild and it's all still internal and people can't see it and maybe can't feel it, that's where I think people don't seek help as often. But with pelvic floor physical therapy, I'm not sure the truth of it, but I've heard that we can improve usually like a grade of prolapse, meaning like we can usually get it a little better, but we're not going to take it from being like external of your body to being internal. I mean, we can only go so much, so those pelvic floor muscles are part of what supports those organs. So that's one thing we can address. And then again, all those strategies. There's also other things. I mean, a lot of doctors will recommend surgery, especially with more severe grades of prolapse. But there's also things called pessary, which is like a little, actually, there's a lot of different shapes and sizes of pessaries, but it's essentially something that you put internally that kind of like is a physical support that kind of lifts those organs and just kind of holds them up, so to speak. So there's like cubes and rings and different shapes. The challenge with pessaries is that you need one that fits like your body perfectly. If it's too big, it's uncomfortable. If it's too small, it falls out. So it's something that takes a little bit of patience and trial and error with. But I've had many patients who will use pessaries either on an everyday basis or sometimes they'll use them when they're more active. So like if they're going to go work out or something like that. So there are options for people who don't want surgery or that's not indicated or warranted. There are, conservative options. But usually that's going to be something you would need to go to a urogynecologist for.
Absolutely. So when I was going through mine, I went through physical therapy first, and then they tried steroid injections, which he didn't really have a lot of faith in, but uh, my insurance would cover it. So he said, let's try and see what happens. Um, I'm now going for the Botox injections because after all the reading I've done and talking to both my therapist and doctor, have learned that that's really the first step I need to take before I can even think about if I need surgery. Um, and so, again, for women who are out there and thinking, what do I do? There, like you said, there are options. And so many of us are going through it. I think it's in a conversation that we shouldn't be afraid to talk about, like I was for such a long time. I figured people would look at me and think I was insane, saying that I was going to a physical therapist who, in a way, I felt initially, and my therapist was wonderful that she took those 3 sessions not to even touch me, um, because I felt like it was so invasive. I felt like it was sexual more than it was medical. But once I started the therapy, I realized it was medical. There was, I didn't have to worry about anything. So, what made you decide to go in this line of medicine?
So I was an orthopedic, well, I still am, more orthopedic based physical therapist, very heavy with manual therapy skills. And I'm also a Pilates instructor. So I kind of by default ended up starting to specialize in core and spine and hip and shoulder and neck and kind of all of that. And then I did a certification for Diastasis Recti, which is abdominal separation, and started working with a lot of those women, which tend to be postpartum. And a lot of them had pelvic, so I asked about pelvic floor issues a lot. And so I would identify, oh yes, you have incontinence, you have pelvic floor issues. And I would try to go encourage them to go see a pelvic floor physical therapist, even just for a few sessions, to make sure their pelvic floor starts to like do their job. Because I was working on the abdominal wall, but the pelvic floor is like the bottom of that deep core system. And so if that's not doing its job, it's like I can rehab part of it, but I can't rehab all of it. So I'm a little more holistic with my approach, and I want 100%, not 80%. But most of those women just wouldn't go because it's just another thing. It's nobody's like, oh yay, I'm going to go to pelvic floor PT. And so it got really frustrating. So I ended up hiring a pelvic floor physical therapist in my office on a part-time basis. And so then I could be like, all right, we're working on your abdominal wall. We want to know what your pelvic floor is doing. I'm going to put you on her schedule. Here's what's going to happen. And I would explain the whole, internal exam and how it all works and why we would be doing it. And if that was something that they were okay with, then they would see her for a session or two, and then they'd come right back on my schedule and we'd be like, all right, great. We know, where your pelvic floor is. how do we now incorporate that into like your abdominal rehab and everything else? And so it worked really, really well. And eventually I was just like, all right, I'm just going to go take this pelvic floor course myself and start doing, you know, that too. So that's kind of how it all started to happen. And I think it's been great because I think it's just something that is really needed out there, and is a really nice adjunct. I mean, I think there's a lot of women out there that even have back pain or chronic hip pain that people can't figure out. And a lot of times the pelvic floor is a player in that no one's really asking about or addressing. So um, yeah, it's been a journey, but I think there's now a lot, and a lot of it is education and women just needing to advocate for themselves. I mean, I've seen a lot of patients over the last few years that unfortunately the medical system has kind of brushed off of like, oh, that incontinence isn't that bad, or whatever, and they kind of didn't accept that, and then they sought out help because in many states now physical therapy does have direct access where you can go to a physical therapist without even having that referral from your provider. We make sure that you've had an internal exam with somebody somewhat recently before we do one, because we want to make sure that the medical side of it is more ruled out before we get to that musculoskeletal piece in most cases. Um, but yeah, I mean, just reaching out to wherever state you're in, the laws are different and the rules are different, and then every insurance company has different rules, so it's not the easiest to navigate. But a lot of times, even if you just start to seek out and look for a pelvic floor PT or provider in your area, you can call them directly and they'll be able to tell you what you need to do in order to go there. So I think it's getting to be more accessible, which is nice, a little less hoops to jump through to get that help. And a lot of it is education. So like personally, I obviously treat women for physical therapy, but I also developed what I call a women's wellness Pilates class, which is just literally the education of the pressure management and how you need to be using your core on a functional level. So it's more geared towards women with what I consider pressure issues, which pressure issues are prolapse, stress incontinence, and diastasis recti. Those are all issues that, it's too much pressure on the abdominal wall or too much pressure on the pelvic floor. And so we start to just bring that awareness to the forefront, because unfortunately with surgery, it's not guaranteed success rates. And so again, there's going to be no research study to prove this. It's my personal opinion, but I've seen plenty of people over the years that had hernia surgery, and then guess what? It failed and they had to have it again, or that had, surgery in the pelvic floor that then failed, and guess what? They had to have it again. And the problem is after these surgeries, there's no rehab a lot of the time. And I think that surgery doesn't, A, you just cut through some muscles or mess with some things, right? And B, a lot of times people don't understand the strategies of how to not make that, I don't want to say come back, but how to set yourself up for success. So if you have surgery on your abdominal wall and then you constantly keep pushing out on your abdominal wall every time you're lifting something, every time you're working out, every time you're yelling, yeah, over time, wouldn't that be more likely to not stay, better, right? Same thing with the pelvic floor. If every time you're doing those things, you're pushing down on that pelvic floor, you're going to put more stress on things. And so all of those concepts of kind of how to get that deep core system to work together optimally would be lovely pre-surgery. But especially, post-surgery, there's still that role of, surgery didn't give you a functional core system. it structurally fixed whatever the problem was, but it doesn't mean that you don't need to do the work to actually get those core muscles back on track. If you had a hard time finding your abdominals and then they just cut through them and did this big surgery, it's only going to likely be harder for you to find your abdominals. So just kind of keeping that in mind. Surgery is not always just the quick fix where it's a one-time in and you're done and you never have to think about those parts ever again. I think the more that you are educated and aware and making sure that those muscles are all kind of doing their job, it's going to set you up for better success, not only maybe preventing surgery, better success if you did have to have surgery, but also getting a functional core system, which can help things like back pain and, all of those other things as well.
Well, I want to encourage anyone who's listening, please share this podcast with your friends and family because they may be experiencing some of these things. Um, when I first got diagnosed, um, for some reason, I was going through my mother's medical records and I found that the reason why she didn't want to travel for the last 12 years of her life, she was diagnosed with pelvic prolapse and she had incontinence to the point that she was terrified to really get in a car and go anywhere. And I'm sad that we didn't know about it. I'm sad that her doctor didn't realize how active of a person she was, um, to have provided her with some treatment. And I'm blessed that my newest doctor that I'm working with is not one who is looking at surgery as the answer. And as she has told me, I've got to put the work in. And,
Hmm.
I'm willing to because um, just a little bit that I've done in the last month, I've seen remarkable changes. I'm not afraid to leave my house where I was about a month ago. And, finding people like yourself who are out there treating individuals like me and letting us know that this is real. And, um, you can make it better. You may not make it perfect, but you can make it better.
Right. Most women I work with prolapse, like if they're having symptoms, usually we can make a lot of progress with the symptoms, right? It's not always what things look like on paper, right? If it says grade 2, it's more about symptoms and quality of life too, right? So a lot of times, I think that's what physical therapy can make a really big change in, is giving you tools to do that. And yeah, we can't just totally fix things, but we can definitely help, and it's definitely worth a try for, I think most people. um it's definitely worth starting there.
Well, I'm so glad that you shared this information with us today. You have some very lucky patients working with you. Um, and hopefully, we can touch base again in the near future and we can compare some of the things that I've learned based on what you're doing as well. So, thank you for joining us today, Rachel.
Yeah, you're welcome. Thank you for having me.
Have a good day. Bye bye
All
now.
right, you too.